thank you, Frank. That was an excellent, excellent case presentation. Very sad story, as I'm sure we are all aware. And I'm also sure to many of my Ugandan physician colleagues in the room, it's not an uncommon one, which is the reason we're having this talk today. And thank you, Jane, for the very kind introduction. I worked with Jane in 2011, and we've been working together ever since. So this is really special. I've been asked today to talk about sepsis. Now, sepsis is the subject of whole conferences, massive working groups, and massive working groups at many international conferences. So I do not think we're going to get much beyond scratching the surface today, but what I'm hoping is that you're going to go away with a few key takeaway points. All right, so we want to understand the importance of sepsis recognition. This is why my first slide has, could this be sepsis on it? If we're not asking the question, we're not going to see it. We're going to discuss a little bit of sepsis pathophysiology to try and understand why cases such as the young lady that Frank just presented actually don't have 3 or 4 different problems. They have one problem, and that's septic shock, which is a killer. We want to talk about diagnostic criteria that are reviewed and published from the various sepsis consensus bodies around the world, and some key management principles. We're going to delve into the Surviving Sepsis Campaign guidelines. We're also going to delve into sepsis management and resource limited settings, which now has its own set of documents. And then there'll be some take-home points. So the first question, what is sepsis? Someone tell me what sepsis is. Because we've used the term 100 times already today. I want this talk to be a little bit interactive. That way no one goes to sleep, it's the middle of the afternoon and the AC isn't working. Yes.
Organ dysfunction secondary to dysregulated immune response.
Were you reading my slides? Are you sure? Life-threatening organ dysfunction caused by a dysregulated host response to infection. The problem isn't just the infection. The infection's what starts it. It's the way the body responds to it. And this is relevant in bacterial sepsis specifically. It's a widely accepted definition, but sepsis is really a syndrome. It's a clinical syndrome with mostly clinical presentations that are highly diverse. We talk about multiple sclerosis having 1,000 faces, well, sepsis has 1 million. So you have to be aware of that it can present in so many different ways. And this is evident too in the fact that the diagnostic criteria that we use continue to be revised and changed constantly. How big is the problem? As Dr. Jane is saying, it's a major killer. It goes beyond cancers, and I don't think it's gone beyond cardiovascular disease yet. Estimated 30 million episodes per year and 6 million deaths. But interestingly, those numbers come from a 2017 systematic review that basically included 27 studies from 7 high-income countries, and then extrapolated that data to include the 87% of the world's population that don't live in high-income countries. Like that. The shaded countries are where that data came from. Now you tell me if that's representative of how much sepsis there actually is in the world. So that 30 million, those 6 million deaths are a gross underestimate of what the actual global incidence and mortality of hospital-treated sepsis is. They found 17% hospital mortality for sepsis and 26% for severe sepsis. And again, we know those numbers are not accurate. In Canada, this data comes from a collection between 2008 and 2009, 30,000 admissions to hospital with sepsis with 31% mortality, 12,000 admissions with severe sepsis, and 45% mortality. Even in a high-income country, with every resource possible, sepsis kills. And globally, even though in many parts of the world sepsis incidence mortality is decreasing to an extent, that's the graph on the left, the case fatality rates are up to 80% or beyond, and these are being reported from the resource poor regions of the world. And this is a statement from the Resource Limited Setting ebook that was published very recently this past year. So it's a killer, it's a huge problem, and this is why we're talking about it today. Okay, question. Which of the following is false? You guys can read. So tell me which of those 4 facts is actually not true. How many people think A? B? C? Okay, I got a few takers for C. D? Oh goodness, we're gonna have to do better at this next time. It's C, yeah, you're right. So the majority of organ dysfunction in sepsis is due to the bacterial pathogen. No, it's not. Okay, so what causes sepsis? Bacteria, fungi, viruses, parasites, right? Different proportions depending on where you are in the world. Gram-positives and negatives, and the end result is a fairly complex interaction between the microbe, the host's immune system, and overall inflammatory and coagulation cascades. Okay? Now, what they say is that you're going to remember 1 point per slide if I'm lucky. So, the main point for this slide is that in bacterial sepsis, as we've said already, most of the negative consequences are not from the bacteria, but from the dysregulated host response. So in the gram-negatives, you've got lipopolysaccharides. In the gram-positives, you've got hepatoglycans in the cell wall. Those go after specific receptors on your monocytes and macrophages, which leads to the downstream negative effects, as you see here. The end result of this is that you've got those pro-inflammatory LPSs, which stimulate your monocytes to release pro-inflammatory cytokines, leading to endothelial dysfunction, so your tiny blood vessels become leaky, activation of your coagulation cascade in a very dysregulated response, leading to things like DIC, fibrin clots in small vessels, inadequate tissue perfusion, results in organ failure, and lactic acidosis and impaired oxygen delivery. So if you think about that for just a second, that explains why every single organ in the body can be affected by sepsis, especially when you get to the shocking phases. So hepatitis, acute kidney injury, delirium, every mesenteric ischemia, gut dysfunction, everything can be affected by sepsis and septic shock. Make sense so far? Okay. This is for your reference. Don't worry, I'm not going to read this. I asked a friend to give me feedback on my slide presentation. He said there are too many words. So I said, this is just for reference for studying later. So, now, this is an interesting slide. This is highlighting the fact that even though we talk about gram-negatives and gram-positives causing a lot of septic shock, okay, and the pathophysiology and the resultant organ dysfunction that results from that, that depends on where you are in the world, because we're not only dealing with gram-positives and negatives here, we're dealing with, outside of the high-income country setting, non-bacterial diseases, protozoal diseases such as malaria, viral such as measles, dengue, hemorrhagic fevers, and those have their own specific pathophysiologies leading to organ dysfunction and shock and death that don't necessarily match what the rest of the world thinks is going on when you've got a septic patient. And remember, what the rest of the world thinks is what dictates those surviving sepsis campaign guidelines. So the point made by this is that we, or rather those working in this setting, have a doubly hard task, because you're not only dealing with one big set of pathogens, you've got a whole other world of pathogens to think about. And I know you know all this already, but this is an important consideration as well. Okay? How is sepsis diagnosed? How do you know if a patient's septic or not? Rapid diagnostic test, point of care, right? SOFA score. Okay, you stole my thunder, seriously? We used to use clinical criteria called SIRS, and this basically meant you were initially dealing with a clinical response from a non-specific insult, and all vital signs based except for the white count, okay? That was the SIRS criteria, systemic inflammatory response syndrome. It was sepsis if you came up with a presumed or confirmed infectious process, and it was severe sepsis if you had organ dysfunction. It was septic shock if you couldn't keep the patient's blood pressure up. You guys all heard of this, right? Okay. What are the problems with this system? SIRS doesn't define the underlying problem. It's a non-specific response to an insult. It might be the patient is cirrhotic with a normally low blood pressure. The patient might be delirious for some other reason. And it's not very sensitive or specific. So in other words, you can have a patient in the ICU with infection or organ dysfunction that actually doesn't meet SIRS criteria. You can have patients in the ICU without infection that do meet SIRS criteria, so it's not completely specific either. And the other big problem with this one is that the definition of septic shock requires hypotension, and all shock is not equal to hypotension, okay? And then there's the whole fact that the SIRS parameters are arbitrarily defined and so on, but the key thing is here that it wasn't perfect. And so in 2016, we came up with the sepsis-3 definitions, which divided infection into uncomplicated infection, sepsis, and septic shock. Got rid of severe sepsis altogether. Okay. And sepsis, as we said here in the front, is presumed infection with a SOFA score greater than or equal to 2. Now, sepsis-related organ failure assessment score is what SOFA stands for, and it's pretty complicated. I would be surprised if anybody in the room hasn't memorized off the top of their head, but it's what's now used to actually make an official diagnosis of sepsis. Great. That's very useful to us on the wards with all those lab values, right? So they came up with something else, the Q-SOFA, which is creatively the quick SOFA score, which is HAT, hypotension, altered mental status, and tachypnea. So think about this for a minute and think about the patient that Frank presented. Was she hypotensive before the end? Her blood pressure was always 140, 160 all the way through. Did she have altered mental status? Yes. And was she tachypnic over 22? Yes. So she met 2 of those criteria, and they're looking for 2 criteria out of those 3 in the quick SOFA score, which makes it pretty useful because you don't need labs, and it's pretty easy to remember. Okay? Again, it's a little bit non-specific in the sense that you could have a positive Q-SOFA and you not be septic, but it highlights the need to look for sepsis. And sepsis is all about recognizing it and getting on top of it early so that we can change mortality rates. Moving across to septic shock. This is sepsis, so infection plus a SOFA score of 2 or greater, plus vasopressors to maintain a MAP over 65, or serum lactate greater than equal to 2 after volume replacement, meaning there's still evidence of organ malperfusion. Essentially profound circulatory and metabolic abnormalities, and once those criteria are met, hospital mortality is more than 40%. Caveat. These definitions, sepsis 3, is not validated and it wasn't actually developed based on any data from a non-high-income country setting. Okay? The advantages of sepsis 3 over SIRS criteria are that it's a bit more consistent. Severe sepsis versus septic shock was always a bit confusing to everyone. And SOFA-based criteria are thought to be a bit more specific. And the SIRS criteria had a white count in there, so we always needed a CBC. But there are disadvantages. This is one of the big ones. So there's an awful lot of criteria there that include labs. So for example, you've got a P to F ratio. What does a P to F ratio calculated properly require? What blood test?
Arterial blood gas.
You need an arterial blood gas. How many times have you gotten that for a patient on the ward? Zero. Yes. Even in Canada, it's sometimes hard to tell you. Coags. Platelets. So you need a CBC. You need a bilirubin. LFTs, right? Those are going to take you a while to come back and the patient's unwell in front of you now. The cardiovascular one is interesting because it talks about mean arterial pressure, which we can calculate from a systolic and a diastolic, right? But once you get over into a SOFA score of 2, 3, 4, we're talking about dopamine, epinephrine, norepinephrine, and not just the drugs that they're on. We're talking about how fast they're running in likes per kilo per minute. And lots of times, we don't have infusion pumps in the ICU. We have syringe pumps. Sometimes we do mechanical drop counting, but we don't always have infusion pumps. It just becomes very cumbersome to use this. GCS we know about, creatinine, and so on. So it's a cumbersome score to use, and not always easy to use in a resource-limited setting. So we have poor generalized medicine. SOFA's never been before used out of the ICU, and I don't think I need to tell you guys that the ICU is not the only place you see septic patients. I would venture to guess that most of the sepsis that you've seen is not in the ICU because the ICU frequently houses a lot of neurosurgical and trauma patients. So there is sepsis there for sure, but there's a ton of sepsis that's just on the ward. The QSOFA doesn't allow for an isolated alternate LVC or isolated hypotension to meet criteria. And sometimes a patient who's septic presents with only one of those. You can have a patient who's extremely delirious and they're septic, but that patient would be missed by the QSOFA. So no scoring system is perfect. It just highlights the fact that we need to ask the question, could this be sepsis? What are we looking for? Okay? I'm purposely staying away from bombarding you with a lot of studies because there could be an awful lot of them stuck into a talk like this. We're sticking mostly to guidelines and recommendations. But this one was from one of my colleagues at MAC who actually came to Uganda some years ago, and he's now working as an intensivist at MAC. So they did a study basically comparing SIRS and QSOFA. Which one has better sensitivity and specificity? And they basically included almost 400,000 patients from almost 40 studies. And they found that QSOFA is less sensitive, more specific than the SIRS criteria. The SIRS criteria wasn't very specific at all. But the sensitivity and specificity of neither one of them is that great. That being said, here in Uganda, we don't need either one of those, and you know why? It's because people at this site have done some excellent work with early warning scores for early detection. And one of them, published in 2015, looked at a prognostic index that took an early warning score and simplified it to be a bidirectional, so respiratory rate greater than or equal to 30, pulse rate over 100, blood pressure over 110 or less than 7, or mean arterial blood pressure over 110 or less than 70, and then temperature criteria, and any change in mental status. Right? And they found that predicted sepsis with actually greater specificity and sensitivity than the early warnings that have been used previously. And when I was here for 3 months in 2013, we did a study here as well looking at specifically medicine and ward surgical patients to see could early warning scores be used. And again, they predict mortality, they predict patients who are going to get sick. And so the point is that clinical vital signs-based criteria, and there are early warning scores popping up constantly, can be used to predict the patient that's not going to do well. So vital signs are really important to measure, track, and abnormalities are something to pay attention to. So, another question. Which of the following is true? How many people think A is true? How many people think B is true? Okay, yeah. How many people think C is true? And how many people think D is true? D is so false, it's not funny. B is actually the right answer here. I know that some of you thought A, but QSOFA was created not really as a screening tool, as a prognostic tool. It's not a good screening tool, and yet that is how it's being used, which is the trick. So we have to come up with different screening tools. So, how do you actually recognize sepsis? Ask the question. Look for those abnormal vital signs, ask the question. And when the organ dysfunctions start to multiply, it's more common for a patient to have one problem with lots of manifestations than to have 3 or 4 different problems. So putting them together is important. Now, that ebook that I was talking about that actually speaks to diagnosis and management of sepsis in resource-limited settings has something to say about this too. So, I know a lot of words on the slide. There were even more before I cut them down. Define sepsis as a combination of acute infection and 2 of the following parameters: respiratory rate over 22, systolic blood pressure under 100, and any acute change of mental state. And so that 1B next to it means it's a strong recommendation on moderate levels of evidence. I'm going to tell you a little bit more about levels of evidence shortly because I think it's important for guideline reviews. The key thing here is that there were an awful lot of members of this panel that live and work in resource-limited settings, and they include specific criteria for diagnosis of malaria and dengue-induced sepsis. Okay? But their most key point was this one. Healthcare workers, irrespective of their proficiency, should be alert to consider sepsis in adults and children with any with acute infection of any etiology. Coming back to the point that it's important to think about and recognize. And with respect to recognition of septic shock, this was defined by the resource-limited setting as define septic shock as the presence of 2 or more clinical indicators of systemic tissue hypoperfusion, independent of the presence of arterial hypotension. And this line kept coming back to me as Frank was presenting because that patient was horribly septic and she wasn't hypotensive. She was not hypotensive, and I was going to ask you if you had blood pressure when she re-presented to casualty at the very end. But they actually make this point in that document. Do not rely on the use of arterial hypotension because it's a pre-terminal event. Because you're dealing with young patients can compensate really well. Tachycardia, they keep their blood pressures. So systemic or hypoperfusion affecting organs can be acidosis, renal failure, hepatitis, delirium. All of that can happen before the patient gets grossly hypotensive. Are we together? Makes sense so far? Okay? All right. So, how do we treat sepsis? How many hours do you have? Okay. So, treatment of sepsis, we've been given 2 documents. We have the Old Testament, the Surviving Sepsis Campaign, International Guidelines for Management of Sepsis and Septic Shock from 2016. These guidelines, first published in 2004, revised 2008, 2012, and 2016. And these are a core part of any talk on sepsis. But we also have a New Testament, which is Sepsis Management in Resource-Limited Settings, edited by these 3 gentlemen here. I've had the privilege of meeting Martin, actually. But there are a lot of other names in this 200 plus page PDF document, which is published open access, by the way. Some of them from here. Arthur is part of that, Jane is part of that. People who actually live and work and know this setting better than anyone. Okay? So actually Jane had brought it to my attention, and I was amazed at everything that has been actually put together and documented. They started this work in 2014. It's the Global Intensive Care Working Group of the European Society for Intensive Care Medicine and another group out of Bangkok, Thailand. And they rewrote a document that had been published in 2012, which had guidelines for management of sepsis in resource-limited settings. But that was 2012, and a lot of that was outdated and based on the 2008 guidelines from before. So in between 2016 and 2017, 8 sets of recommendations for care-centered patients were published and summarized in this ebook, which is now open access online as of this spring. So it's something you should all look up. I should put a link to it in the slides, but I can get that. Permit me to have a McMaster EBM moment here. So when you're talking about guidelines, you have to talk about the grade system, okay? The grade guideline machine, and I stole this slide unabashedly from my colleague Dr. Rochework, who is an intensivist at MAC. This machine incorporates quality of evidence, number one, but also patient's value and preferences, resources, and balances pros versus cons to come up with, is this a strong recommendation? You should all follow it or have a good reason why you're not. Or a weak recommendation, meaning if someone decides not to follow it, it doesn't matter so much, okay? And we are talking about quality of evidence. Obviously, high quality evidence is randomized controlled trials. Moderate might be, biased RCTs or upgraded observational studies. Lower quality might be really well-done observational studies, and very low probably aren't in the guidelines. And if you've got an RCT or an observational study that's got a huge magnitude of effects, no confounders, or no threats to validity, you might even upgrade that. You might downgrade the studies in terms of its quality of evidence if you've got methodological issues with the RCT, biased, inconsistent results, using subgroup analyses a little too much, or high likelihood of reporting bias. Okay? And this is all information you can get online. But the reason I'm bringing it up is because when the resource-limited setting working group was putting their guidelines together, they paid attention to this, but they put extra emphasis on how certain are we, if you look at line number 3, about the balance of benefits versus harm and burden. Understanding that, especially when it comes to some of the more gadget-based management devices that we use for septic patients in critical care, there can be a lot of harm if you're not able to monitor correctly. For example, resource implications, availability in low and middle-income countries, and affordability. So they weighed all of that in as they were making their recommendations. When you see a 1B or a 2C or something like this, this is what it means. So in the Surviving Sepsis Campaign guidelines, you will see this is a strong recommendation based on moderate quality evidence. That would be the same as what we used to see, which was a 1B recommendation. Does that make sense? Because the one document uses the numbers in the letter system, the other document uses the prose system. And it's just important to know that if there's a 1 in front of it, it means they've really thought about it and it's something to consider. A best practice statement is not a graded statement. It's something that is highly recommended and usually pretty unequivocal. And there's implications for patients, clinicians, and policymakers based on the strength of recommendations. Okay, that's it for the McMaster EBM. We'll move on to something more interesting now. So, from the Surviving Sepsis Campaign guidelines, the best practice statement that leads it all off, and this is what we remember. This is the most important one. Sepsis and septic shock are medical emergencies. The minute you recognize it, start treatment and resuscitation. Principles of management in general: resuscitation, antibiotics after blood cultures, source control, vasopressors, noradrenaline for refractory hypertension, inotropes, other things to consider in refractory hypotension, supportive care and monitoring, which I probably should put closer to the top because that's very important, preventive strategies, other care and rescue therapies. There's a lot there. So we're going to talk about the initial management of sepsis, and we're going to compare surviving sepsis campaign guidelines to what can be done in practice in a more resource-limited setting. We're not going to get too deep into specifically critical care management, placement therapy, mechanical ventilation, all that stuff, because most of the sepsis that every one of us in this room is going to see is going to be outside the critical care unit, and knowing what to do outside the critical care unit, I think, is quite important. We can do a whole nother talk on the critical care unit management of sepsis. So, the initial resuscitation from the Surviving Sepsis Campaign guidelines. We recommend that in the resuscitation from sepsis-induced hyperperfusion, at least 30 mils per kilo of intravenous crystalloid in the first 3 hours. And then, after the initial fluid resuscitation, give additional fluids based on a reassessment of hemodynamic status. So how much fluid are we giving? And that's initial MEP. And a lot of times you can see patients get very, very, very swollen and edematous from giving way too much fluid. The principles of that 30 mil per kilo is that, remember how I said septic shock, endothelium is leaky, right? So you've got a relatively increased vascular space to fill in order to bring up the blood pressure. So that's what you're trying to replace. We grew up, most of us, with Rivers, 2001, right? Early goal-directed therapy, where additional fluid resuscitation is based on a central venous blood gas, a specific MAP, a transfuse based on a hematocrit. We had specific endpoints that we were told you have to adhere to, because Rivers' study improved mortality. However, the endpoints are not so clear-cut at this point because nobody else has been able to reproduce those results. And part of it, of course, in those 3 papers, Arise, Process, and Promise, patients all got that 30 mils per kilo. Patients all got early antibiotics. So, comparing interventions to sort of standard practice was Rivers at that point. That being said, we don't anymore recommend that you go straight for those specific numbers, CEP, etc. Fluid responsiveness now, according to the guidelines, again, and we're going to get to the other documents shortly, but the fluid responsiveness, the suggestion, not strong recommendation, is that dynamic, more than static variables be used to predict fluid responsiveness where available, and we'll get to what those mean shortly. They also suggest guiding resuscitation with lactate. But again, lactate's a useful marker, but not a completely direct measure of tissue perfusion. It's actually impacted by other things, liver dysfunction, beta-adrenergic stimulation. It does still tell us something about tissue perfusion, but it's a weak recommendation. So the first thing that we do for assessing fluid responsiveness is frequent clinical assessments. Heart rate, blood pressure, markers of perfusion, urine output, and mental status. Okay? With respect to static measures, these are central venous pressure and pulmonary arterial blood pressure. Those are not recommended by the guidelines. The dynamic measures, pulse pressure variation, which I'll show you in a second, or systolic pressure variation, and this passive leg raise. Have you guys heard of this? You know what that is? Get to it shortly. Ultrasound can also be used to look at your inferior vena cava as a surrogate marker for filling pressures. Okay? CVP doesn't have a lot of data behind it, not even for trending anymore, which is good because getting central lines and CVP monitors in our ICUs here in Kampala is not always the easiest thing to do anyway. So don't, because it's not in the guidelines, but it's not recommended. In terms of pulse pressure variation, typically this requires an arterial 1 blood pressure drops if the patient's still volume deplete. Okay, but the most highly recommended one is this, passive leg raise. Because when you raise a patient's legs to 45 degrees, you're essentially giving them increased venous return from that peripheral circulation. And you're assessing clinically whether their blood pressure or markers of perfusion respond to that. Believe it or not, we use this at home. And it's recommended to a degree. The other thing you could do, practically speaking, is give a 500 ml bolus of assess. Because once you've given that 30 ml per kilo initial volume bolus, what you do next depends on if the patient still needs it, because there are harms that can result from giving too much fluid just as much as from not giving enough. Okay? If the patient isn't peeing at that point, certainly it could be because they still need fluid. It could also be because their kidneys aren't working all that well. So there's constantly lots of moving parts, but you have to ask the question, does the patient still need fluid, and what tools do I have to make that determination safely or not? Okay? So if the patient's improving, give them more. If they're not, consider stop. Have I lost? So, another question. What accurately describes your approach to initial fluid resuscitation? Assuming you had everything available to you that you wanted. How many people think number one? I kind of think number one. How many people think 2, 3, or 4? Really? Okay, so this is getting into this question of what fluid is best. And I know that when we say crystalloid, there's lots of different crystalloids to pick from. And believe it or not, there are some of my attendings when I was in training for critical care that used to have debates about Ringer's lactate versus normal saline and other such things. Fine, they have time on their hands, they can do that. There's lots of papers published on this too. However, the Surviving Sepsis Campaign guidelines elect not to pick sides on that. They recommend crystalloids for initial resuscitation. That's a strong recommendation. The recommendation for albumin is weak, not very supported by evidence. Now, and I'll tell you a slightly funny anecdote, and I'm sure some of my colleagues here can relate to this. If you're trained at McMaster University, you resuscitate with quite a bit of albumin. If you're trained at Western, which is an hour's drive away, you never give albumin. So it's very practice and resource dependent, and it's a weak recommendation. So use your crystalloids. Albumin is super expensive, and it's a blood product anyhow. So when we talk about which type of fluid is best, normal saline has pros and cons. Okay, it's available. It's probably the most readily available. It's not harmful in traumatic brain injury because it's not hyponatremic. But it is hypernatremic. It's a little hyperchloremic. It's acidotic. So there are cons to it too. Ringer's lactate is probably the most balanced solution that we have, but it's got potassium in it. So a patient with renal failure, you probably shouldn't use it. It's got a little lactate, so if you've got liver failure and you're not going to clear your lactate, maybe a little bit of harm there. Essentially, they're fine. Both of them for resuscitation. Starch solutions, so your Volumen, your Pepspan, other head starch, they're not good. And I hope that we're not using those so much. They cause renal failure and death. Albumin can be useful, but it's super expensive and not strongly recommended in the guidelines. So the bottom line basically is crystalloids are good. Now, when we're talking about initial resuscitation in our resource-limited setting, okay, and I've been very, I will admit I didn't get through all 250 pages of this document, but there is so much excellent work that's been done there, and it's an amazing document. They address all these questions. How much fluid? How do we assess for fluid responsiveness in our setting? And what kind of fluid should we be using? some of the time it depends on what you can find in your cupboards. This is one of our intensivists here, and the charge nurse, and I'm not sure what it is that they've found there, but it looks like a box of antibiotics. Anyhow, they have a big table in that chapter on hemodynamic support that goes through, well, what are our simple bedside tests for tissue perfusion? Cap refill, skin modeling scores, skin temperature gradients if you've got a thermometer available. They're non-invasive, they're low cost. This isn't a patient who can't afford very much at all, like the patient that Frank was telling us about. I'm unsure how easy skin modeling honestly is to do in this setting, but it's one of the ones that they recommend. They also recommend the passive light rays as some indicator of, is the patient still fluid responsive or not? They talk about crystalloids being the first choice, but they say wards should stockpile this. You don't want to be running around looking for a bag of ringers or salmon when you have a septic patient who needs it now. And that's not always the norm, because sometimes the wards can't stockpile this. In terms of the amounts and timing of intravenous fluids, certainly give your 30 mL per kilo up front. That's a 1A recommendation. But be extremely cautious if you have no access to vasopressors or mechanical ventilation. And that's because when they take these studies, when they take the Surviving Sepsis Campaign guidelines and extrapolate them directly to populations in, well, one study was in Zambia, the mortality rates with that early goal-directed therapy and lots of fluid, they're higher. Because once a patient becomes hypoxic, or goes into ARDS, or gets fully overloaded from a pulmonary standpoint, mechanical ventilation is largely unavailable. And so that's actually highlighted in that document. They also advise no fluid boluses of severe malaria or dengue. And the reason for the severe malaria piece, I think in part at least, is because of the results of the Peace trial in Kenya, which was pediatric population, granted, but severe malaria managed with, intravenous fluid boluses and essentially the same kind of early goal-directed therapy. Again, that mortality rate was quite high, and we don't know exactly why. But until they do know, they're saying be cautious in that population. They include scores for interpreting cap refill time in just ones in kids. They include scores for skin modeling. And the point of this is not, this is the only way to do it. The point of this is have a system, have a protocol, have a set of monitoring parameters, and follow it. It's very hard when care is somewhat piecemeal. These are factors outside of your control. A patient comes from Mwembe to Guru, back to Mwembe, because the care that each patient needs is divided across the city. But figuring out some way to say, the one thing I did notice, you guys were tracking that GCS. You said her GCS is 14 and 15 when she left. Now it's 10. And keeping track of other parameters to sort of indicate she's getting better, she's not getting better, she's responding to therapy, she's not responding to therapy, that's the important piece here. In terms of transfusion, the guideline's pretty simple. This is from Surviving Sepsis, again. We know this, right? RBC transfusion will occur only if the hemoglobin is under 70. In the absence of circumstances such as severe hypoxemia, acute hemorrhage, myocardial ischemia, or maybe hemolysis, right? In a setting of sickle or malaria or what. The transfusion trigger of that 70 is supported by several studies, TRIC being one of them, TRIS, Australian Patient Blood Management Guidelines. Surviving Sepsis supports a slightly higher threshold, but just a practical way to think about it, if you consider that is the patient bleeding or unstable? Like, this patient was bleeding. This patient had, 2 liters of blood sitting in the peritoneum. And the question was asked, could that have been still the cause of the ischemic ATM down the road? If the kidneys are ischemic for 30 minutes, they can develop, they can fail, renal failure, ATM, right? So that pre-renal episode 30 minutes, 40 minutes, an hour, leads to ATM, which can be persistent for days and weeks. So that pathophysiologically speaking, it makes sense. Consider the patient's reason for admission, consider the patient's wishes, and consider comorbid conditions. 70 is your usual trigger, probably 70 to 100 if evidence of some of these other factors. Over 100 rarely if ever need a transfusion. But I'm fairly certain you guys are going to see more hemoglobins that are low in a septic patient than I would, because your patients are potentially more malnourished, have had more issues with iron deficiency and so on, sickle cell, that kind of thing. So it's an important thing to think about as you're resuscitating your patients as well. In terms of diagnosing sepsis, going back to the Surviving Sepsis Campaign guidelines, appropriate routine microbiological cultures including blood, and then get them on appropriate antibiotics. Best practice statement, ungraded, just do it. Now, strong recommendation, give IV antibiotics as soon as possible, within an hour if you can. Our emerge departments and our critical care units struggle with that 1 hour, but we try. Another strong recommendation, empiric broad spectrum therapy with one or more antibiotics to cover all likely pathogens. Another strong recommendation. Why is this important? Well, just to remind us all, every single hour in delay is another 7 to 8% increase in mortality. And if they receive ineffective antibiotics, mortality risk doubles, and those are a few studies that are cited there. I don't think those statistics have changed all that much. In terms of stewardship, because if we give to, and I'm going to show you a paper shortly that shows you how relevant this is, but in terms of giving broad spectrum antibiotics, right? Our ID physicians cringe a little bit because we're just inviting resistance, right? Well, empiric antimicrobial therapy should be narrowed as soon as you get a pathogen back, and sensitivities, and or the patient's getting better, okay? Weak recommendation regarding duration, because duration all depends on source control. Best practice statement, daily assessment for de-escalation of antimicrobial therapy. So if you started a patient with no cultures on 3 different antimicrobials because you don't know what they have, every day when you're rounding on that patient, can we bring the antibiotics more narrow and focus in what's our resistance pattern, etc. And then another weak recommendation regarding procalcitonin levels to shorten the duration of antimicrobial therapy in sepsis patients. Not so relevant. I can't get it back that fast in the setting where I work, so I'm sure that the same would be true here, and it's also a weak recommendation in the other document. This is really important. So, a specific diagnosis of infection requiring urgent source control should be identified or excluded as fast as possible. You guys were ultrasounding that woman repeatedly. That was really important. And I fully understand the surgeon's reticence to actually do something once you could actually identify quite a bit of free fluid in the perineum, because she was really, really sick at that point. But if there was some form of source of infection there, that is not going to be controlled with IV antibiotics when you need source control. And if the patient is on appropriate therapy and appropriate antibiotic therapy and they're not improving, you have to keep asking yourself every day, re-examining that patient, is there new evidence of a source that we haven't found yet? So one of the ones, we had a patient, a school teacher who was in his 50s, had been on a bus trip with a bunch of students and came in, and he was one of the sickest patients I'd seen in a while, on 3 pressors, on life support, and he was just getting worse. And came in the following morning, so we watched him for 24 hours. The next morning we came in, and he had developed a flaming, red-hot knee. He had a septic knee, and it was strep vaginus, and that's why he wasn't getting better. Drained the knee, washed it out, went to recuperating and came back, and he started to improve. So sometimes the source isn't evident right away. You have to keep reassessing and re-examining, because if it's not evident day one, it's going to be evident before too long. In the limited resource setting, how do you identify the underlying type of infection? From the guideline, a structured history and a systematic exam. Every 6 hours if you need to. More collateral if you can get it. What happened at the other hospital? Exactly what you presented, okay? Other really key piece is to know what your local infectious epidemiology is. And you guys are getting more and more of that here locally now. We have this thing called a biogram at each of the hospitals where we work, and that says, okay, when we get such and such a bug, it's usually resistant to this, or 80% of it is sensitive to this antibiotic instead of this one. And that's how we can keep track of our antimicrobial stewardship. So you want to recognize and pull that information wherever it's available, and you add as many diagnostics as you can. If it's an ultrasound scan and you can get it, then get it, and be able to pull out all of the information you can out of that diagnostic. I was speaking to some of the emergency medicine residents yesterday, and we were going over ECGs in some very immense amount of detail. And when we were going over axis is one of those nerdy cardiology aspects of the ECG, and going over quite a bit of detail. And we were reflecting on the fact that an ECG is easier to get than, say, an echocardiogram. And if you can pull out all the information possible out of that simple ECG, you're doing your patient a favor, especially in a setting where you don't have every diagnostic that you want. So the same would apply to this. In terms of coming up with a causative pathogen, you get cultures if you can. Even if you can draw the blood and send it off, because that is going to help you narrow your antibiotics later, try to prevent antimicrobial resistance, multi-drug resistant organisms, but don't delay your antibiotics. They include very specific recommendations for malaria, viral infections, TB screening, and HIV-infected patients, all of which is really important in this setting because I think it was Jacobs that did a study, Jay had mentioned to me, I didn't have time to look it up last night, but where they actually had, in the emergency department at the old model site, looking at patients coming in meeting criteria for early sepsis, how many of them had a gram-negative or gram-positive blood, how many of them had mycobacterium. And a lot of them did have mycobacterium, so that's an important consideration as well. In terms of picking your empiric antibiotic therapy, I really, really love this diagram. So, here you are. You suspect sepsis or septic shock. You start them on empiric antibiotics. What informs that decision? Well, what's the likely source? Extreme physical. What's the local data tell you about resistance patterns, about common bugs? Where is the patient coming from? Was the patient in 3 hospitals in the last week? Is the patient been only at home, never in hospital before? It's going to be a very different set of risk factors, right? Is the patient immunosuppressed? Are they co-infected with something else? You guys have ruled out HIV, you guys have ruled out hepatitis. I never heard of you ruled out malaria or not, but assuming you did. What risk factors do they have for multi-drug resistant organisms? And then you get them onto their empiric antibiotics. The minute you have a culture with a known source, you get source control, and then you can de-escalate. Okay? So this is a useful set of operating principles to think about when you're in that situation. Now we know that a lot of the patients get ceftriaxone because that's what you guys have and that's what's available. But for some patients, that's going to be like giving them water. For some patients, it's going to work just fine. And it's the job of the astute clinician to think about, is that antibiotic going to make a difference? Because if it's not, what could I do that might make more of a difference? In terms of the recommendations from the working group, recommendations and suggestions on infection control in patients with sepsis or septic shock in resource-limited settings. I think this is the key one. Poor outcome is associated with inappropriate antibiotics, so empiric therapy should aim to cover all expected pathogens and likely resistance patterns. Research groups, in close collaboration with stakeholders, should provide microbiologic data from sentinel sites throughout North America but it's an important one to think about. And one of the anesthesia SHOs in 2013, who's now an anesthesiologist, Peter Gaba with Jeanette, and then the anesthesia staff working with them, actually studied in 110 or 111 ICU patients in Uganda what the cultures day 1 grew and what cultures day 48 to 72 hours later grew for ICU patients. They found a prevalence of multi-drug resistant bacterial species of over 50%, with the main antibiotic that was actually useful in the pandemic. And what was the most associated with nosocomial infections? Ventilator support and severe TBI. So this highlighted the need to develop a policy of antibiotic stewardship, infection control, surveillance, right? So knowing your own local data is crucial. And more of those studies are being done by probably people in this room, people in critical care anesthesia, people who are working at Chirudu, and that's excellent, and really important work. What are some of the challenges to source control in this setting? Well, you have a lot of different conditions to consider. You have variable access to diagnostics, variable access to timely search and source control, right? As we heard, your job is not easy. We try to get source control if we can. We try to think about 12 to 24 hours. We try to get rid of indwelling devices. So if a patient, in Canada we have a lot of indwelling devices. They'll have hardware, they'll have a dialysis line, they'll have a central line, things like that. If your patient happens to come with something like that, take it out. X-ray and ultrasound are not poor imaging techniques. They're very useful, especially if you do them serially and watch for changes, which is exactly what we heard over here. And I know that those are a little bit more readily available, so use them. We're getting close to the end. How long has it been? Okay. We'll wrap up here shortly. I've got a few more things to just run through quickly. Which of these ones is false? Let's just move through it. The correct answer is evidence supports the mortality benefit with adding vasopressin once the MEPI doses are over a certain threshold. This is now talking about vasopressors, okay? Surviving Sepsis talks about MESAU-MEPI as your first choice vasopressor. Great. It's the first choice basically for every kind of shock, including sepsis. They also suggest adding vasopressin or epinephrine if MESAU-MEPI is not enough. Okay? That's also great, except for the fact that sometimes you don't have those, right? I put a little review in here, and you guys will probably get a copy of these slides, I suspect, if people want, they can email me. But looking at the different alpha and beta receptors that are impacted by the different pressors, okay? And the key thing to notice there is that MESAU-MEPI and EPI look like they're mostly the same, but EPI has more negative effects. However, sometimes EPI is the only thing you have. It's probably the most readily available pressor around, so know how to use it. Because if you don't have anything else, it doesn't matter what the guideline says, use the epinephrine. If shock is not resolving, there's a couple of other things to think about. Further hemodynamic assessment. Is cardiac function poor secondary to sepsis? You can have a septic cardiomyopathy, and that is a best practice statement as well. Moving over to the other document, the low resource setting document. There are some important considerations here. We recommend against the start of a vasopressor before initial fluid resuscitation. Sometimes in a more another setting, you might start your fluids and start your noradrenaline at the same time. Well, don't do that here, because give them fluids first. They may not be able to get a central line. Giving peripheral pressors is not without risk. Use norepinephrine if you have it, first line. Use dopamine or epinephrine if you don't. Use a central line if you can get it, and use a syringe or infusion pump if you can. It's always if available. And notice the 2D, right? Weak recommendation. No real evidence for it. It's just we know it's safer. They even talk about inotropes. The problem with inotropes in this setting is that how do you measure perfusion if a patient's on an inotrope such as dobutamine? How do you measure changes or increases in cardiac output? It's hard to do, right? You need some way to measure that cardiac output. So again, they speak about different ways to do it, looking at peripheral perfusion, looking at catheter flow, all that sort of thing. But it's hard. A practical approach for when shock is not resolving. Go back to basics. What's your diagnosis? Have you got the right one? Have you missed source control? Is the patient still losing blood from somewhere that you haven't found? Are you dealing with an obstructive form of shock? Has the patient developed a PE? Right? Have they got toxins on board? So one of the things that I was reflecting on was that this patient had high blood pressure, had been put on some antihypertensives. Now, if she had come with suddenly low blood pressure, now you're battling the effect of the antihypertensive she was on. So that's an important question to ask. What medications have they taken? That's the exogenous toxin that's still on board. Are you dealing with a septic cardiomyopathy? Have you got source control? Have you developed a new source of infection? And the patient may be acidotic or may have low calcium. So both of those things can impact blood pressure, hemodynamic stability. And calcium, for example, if you give the patient quite a bit of blood, their serum calcium can be low, right? And then they're not clotting properly, and they may have impaired cardiac output. The acidosis piece is important to remember as well. Beyond a certain pH, no matter how much norepinephrine or epinephrine you give a patient, it's not going to be effective. And so sometimes, as you correctly identified, that patient was probably Kruisselbrink, probably severely acidotic, and sometimes if you have access to some sodium bicarbonate as a rescue measure, even if you can't dialyze, sometimes consideration of something like that can help. The monitoring and supportive care piece. This is a tricky one. We want to put the patients in the ICU, right? Yes, we want to, especially sepsis and septic shock. But we can provide monitoring and supportive care on the board too. We're monitoring vital signs. We're monitoring markers of perfusion. We're looking for developing or progressive signs of an infectious source. We're looking for complications of our treatment, and we're looking for evidence of progressive multi-organ failure, and we're documenting it clearly so that the next physician or nurse or practitioner who sees that patient isn't guessing about what's happened. You know, we have a flow sheet. Maybe we develop a high dependency unit at Trudu where we closet the patients who are septic and have slightly low blood pressures. And what we're doing then is we're keeping track of their vital signs and their vital signs response to fluid boluses and over time after antibiotics, because that still counts as good critical care for septic patients. So we have to think about that. Both sets of guidelines deal with steroids. Basically, they're okay, which surprised me a little bit because of all the infectious risks in the low resource setting, but they went ahead and suggested hydrocortisone 200 milligrams a day if the patient's hemodynamically unstable and responding fluid. That being said, there is not a lot of evidence that they make a speck of difference. There's a very, very, very tiny signal that maybe they reduce long-term and short-term mortality, but the evidence is very poor. And there's a very tiny signal that they may actually get patients out of hospital faster. This was in a huge meta-analysis that was just completed, including all of the major steroid studies with a priori subgroups. So, yes, give them. We all give steroids if our patients are not doing well, especially if they're really shocking and on pressors already, but they don't actually work, at least not according to the evidence.
What is A priori?
Sorry?
A priori.
A priori?
Yeah.
Oh, a priori just means, you know how if you do subgroup analysis after the fact, after you've already established what your outcomes and your results are going to be, those subgroup analyses are always suspect. The a priori means you established it up front. So this is my, again, stealing from Dr. Rochelle, this is my colleague's way of saying he did it the right way. So. Glucose control, again, the two sets of guidelines agree. Strong recommendation to monitor sugars, but not to aim too low. Okay? In terms terms of nutrition, use the gut whenever you can. Keep patients eating. Strong recommendation. In terms of renal replacement therapy, the surviving sepsis guidelines are quick to say if the patient doesn't have indications for dialysis, don't have to dialyze purely based on a high creatinine or decreased urine output. It's a weak recommendation. But in the other set of guidelines, the suggestion is that patients with sepsis-induced AKI that need renal replacement therapy might be able to be supported by PT. And I included this because there's a lot of work that still needs to be done here. Dialysis is so hard to get. But this was the statement that was in the document. And I'm including one more aspect of supportive care, which is mechanical ventilation. This is from the Surviving Sepsis Campaign guidelines. And I'm including this one. I said I wasn't going to go too much into critical care aspects of this. But this is a really good example of how intervening with mechanical ventilation and actually following these guidelines, using a higher PEEP for sepsis-induced moderate to severe ARDS, prone positioning, and so on. When you're talking about a lower resource settings where it's difficult to make a diagnosis of ARDS because you need chest imaging, where it's difficult to actually titrate high PEEPs, lower FiO2s because you need regular blood gases, where using high PEEPs means that you need to monitor for complications of high PEEP, like barotrauma. It just highlights the incredible difficulty of caring for patients in these settings using that specific set of guidelines. And honestly, as I was putting this together and thinking through it, again, highlighted to me how hard my colleagues work in this environment and how much harder their job is really than mine. And again, highlighting the additional work that needs to be done in this area. The Surviving Sepsis Campaign guidelines go into goals of care, and I'm including this. They have some best practice statements that talk about set goals of care, discuss prognosis with the families, incorporate goals of care discussions into treatment plans, address them within 72 hours. All well and good, but in the high-income setting, I know we see our share of young patients for sure. But you guys are going to end up seeing a lot more of those patients than we are, just based purely on the average age in Uganda compared to the average age in Canada. And again, thinking about the stakes that you're dealing with a 34-year-old woman or a 30-year-old woman who's just had twins, and that is the septic patient versus my 85-year-old with devastating urosepsis who's got a number of comorbidities. It's a different environment, a different group of patients. Which is why I'm so happy to see that the incredible work that the working group has been doing for the resource limited setting document. So, quick summary. I said I was going to have a couple of takeaways for you. Recognize sepsis, ask the question, look for it. Think about what's the right amount of fluid for this patient, what are the right, most targeted possible antibiotics I can give this patient, how quickly can I get it to them? How am I monitoring this patient? Am I monitoring them regularly? Am I documenting it so that the colleague taking over after me is actually able to see what I've been doing? What are alternative diagnoses? If the patient is not getting better and we've got all these separate issues that are going on, take a step back, look at the whole patient. Have I missed another source of shock? Have I missed an alternative source of sepsis? Septic patients are highly dynamic. Reevaluate frequently. And communicate with the patient and family because they can give you information. They need to know what's going on. And as we heard, they all have their own ideas about what the outcome's going to be. The WHO and low-income country working groups are working on this, but in reality, that's going to be all of you guys too, because you're frontline clinicians here. So, some concluding thoughts. Sepsis kills without discrimination. Suspect it, look for it, recognize about septic patients here that needs to be told. And you guys are going to be the ones to tell it. And going forward, I hope that we can work together on making that story more visible, because that is how positive change in this is going to happen. I want to say thank you to all of you for having me here. I've been coming to you again since 2011. I'm here every year.